But anyway, so I grew up in Cleveland for the most part. I went there to college and med school at Case Western Reserve University. And then I matched at Baylor College of Medicine to do my 6-year residency in the medical center, and that's what brought me to Houston. And so I married a Texan when I was down here, and they're not portable. And she said, there's no way I'm going up to Cleveland or anywhere else where it snows. She went to college near Boston and said, I'm never living permanently where it snows and it's cold. So we stayed, and we have 4 kids, and they're a handful, all of them, but they're good kids. And after I finished my residency 15 and a half years ago, I opened a practice in Pasadena, in Southeast Houston, in Clear Lake area. And I put up a shingle and proved it was still America, and you can go into business for yourself. And I added a partner 3 years later who also trained with me in the medical center. And, we work very hard, and I'm a full-time private practice urologist. I do major surgeries. I take care of kids through adults, through the elderly, and we do pretty good work on medicine. And then what happened was that right around 4 years ago, my wife was listening to Dennis Prager and on the radio, and he said, "Where are all these doctors in this healthcare debate?" Because it seemed like the politicians were discussing it and various other groups, but the doctors seemed to be silent, or at least not involved in the debate. And there was a physician she heard on Dennis Prager by the name of Hal Schurz, and he started a group called Docs for Patient Care. It was a grassroots physician organization that basically was there to defeat Obamacare. And it was a grassroots organization. It was highly disorganized. They went to Washington several times, were involved with rallies against Obamacare, et cetera, et cetera. So, I'm very, very busy in my practice. I work, at least 80-hour weeks. And I've never been involved with politics or going to Washington or with the process at all, which is, I think, a mistake of the physician community as a whole and why we're in the state we're in as far as healthcare. And so I came home at night, and Daniela told me about this organization. So I went to the website and I signed up. Then I got this email, "Come to Washington." And I talked to Daniela, and she said, "Well, look, if this law actually passes," and the Senate had already passed it, this was 2010 in the beginning, and if this law ever passes and we have socialized medicine, 20 years from now, our kids are going to say, "You were there. What did you do when all this stuff was coming down?" And, we need to do something. And because, I happen to blame my father and the previous generations of physicians for allowing the healthcare system to get to where it has gotten. And so I signed up for a trip to go to Washington, and I bought my plane tickets and hotel room. I rescheduled 50 patients and about 10 surgeries and whatever, and went up to Washington and planned the trip. So I get up to Washington, and one of the groups that helped us form and originate is the Heritage Foundation. And we had a meeting at the Heritage Foundation, so I've never been there. So I walked into this room, and it was like walking into a wake. And it wasn't an Irish wake. There was no celebrating. It was a very depressing room because 2 days earlier, President Obama signed ObamaCare into law. And since then, I've been sort of a grassroots physician activist. I've been to Washington a dozen times. I've met with countless congressmen and senators, and been on the radio many times. And it's kind of been a passion to educate people about what's going on with our healthcare system. So I passed through a little diagram that sort of explains the healthcare law in a nutshell. And the reaction that I first saw it was, my reaction was that I started laughing like this. You can't be serious. And the reality is it is that serious. And so I'm going to tell you a story. And this is a real story. So this last, at the end of the summer, I was consulted about a patient that came through the emergency room. And the patient had blood in the urine. like a lot of blood in the urine. And she's never had blood in the urine before. And so she came into the hospital, and the emergency room called me, and they said, yeah, she's stable, you can see her in the morning. Okay. So I come in to see the patient in the morning, and her urine is really, really bloody. And I ended up taking her to the operating room very shortly after that to take a look in there and make sure there's no bladder cancer. And I saw that when she was admitted to the hospital, the hospital is a fairly reputable hospital, but they're on electronic medical records. And electronic medical records is not just electronic medical records for hospitals, it's electronic ordering. And she came in the hospital, they activated these standard orders. And as part of the standard orders, there are certain things that hospitals have to, or if they want the governmental money, if they want the money from the federal government and all these incentives, they need to follow all these quality measures. And one of these quality measures, and I'm using quality in quotation marks, one of these quality measures has to do with prevention of blood clots in legs, deep vein thrombosis, so people don't get blood clots in their legs. But what happens is when somebody checks a check mark on activating standard orders, these are some of the orders that get activated. So here you have a woman who's bleeding, like really bleeding, and the nurse walks in there in the middle of the night, sticks a syringe into her abdomen of blood thinner so she doesn't get blood clots. So since that moment, her blood count dropped another 2 hemoglobin points, which is about two more units of blood that she bled. But and that was terrible. I'd actually ended up stopping that medication and waited a little bit and took her to the operating room. And thank God she didn't have any cancer, and she's fine. And I thought, okay, fine, that's just coincidental. Within a month, that same thing happened 2 more times in 2 different hospitals that I go to. So what's happening is literally the healthcare system is being taken over by protocols. And you know what is really scary about this story? It's not Obamacare. It's actually from before Obamacare. This has to do with the American Recovery and Reinvestment Act of 2009. There was an anniversary this week. It was the 5th year anniversary since President Obama signed this law. The shovel-ready jobs, $780 billion a year that got added to the baseline budget. So 2009, 2010, 2011, 2012, 2013, and 2014. It's about $5 trillion. And in that, there's Section 3000. And Section 3000 of the American Recovery and Investment Act is actually more scary than Obamacare. Because Obamacare hasn't directly harmed too many people yet. It's harmed some people, and has already delayed care, and including care for cancer patients in my practice. But this law has actually been in effect for 5 years. And so what's happened is every hospital in the country and every doctor's office in the country has either implemented or in the process of implementing or will be implementing electronic medical records and electronic ordering systems. And it means that patients, when they come in, get treated into protocols. And, you know, everybody's the same. And and that's basically what happens is everybody either gets the same treatment, whether it's good for them or not. And this is more than just an information grab, which it is. It's turned every doctor and every nurse and every hospital into a data collection mechanism for the federal government. And it's actually really, really and truly happening. And that when anybody goes to a physician, or more importantly to a hospital, they know what your ethnicity is and what your race is, and if you're married or single and do you smoke. They're reporting what your BMI is, how fat you are, because that's calculated based on your height and weight. And they're making sure you got a pneumonia shot so you don't get a pneumonia, whether you want it or not. And they're making sure that you're not getting blood clots. So even if you're bleeding, sometimes you're going to end up getting a blood thinner. And this is really, 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 really scary. And what drives this is money. And these hospitals, I don't think they're evil. I think they're just following the government, following the laws, and following the money. Because what happens is if they meet all these quality measures, and this is the word quality that's used, then they get money. And this is a lot of money. It's so much money that you have hospital corporations that spend tens of millions of dollars doing electronic medical records and electronic ordering, and then they figure out that there's a software package that captures that data better, and they will scrap it and start from scratch. And the reality is that in the healthcare dollar, physicians make less than 12%. Physicians account for less than 12% of the healthcare dollar. So the people that actually take care of the patients are actually the smallest part of the pie. And so this is driven by large pharmaceutical companies, large hospitals, large hospital corporations, and that's really, really scary. And what happens is this also dovetails into ObamaCare. And the reality is, and all of us have seen what happened with ObamaCare as far as its implementation, but that's really the tip of the iceberg, and that's what's really scary. Now, I'm not here to scare you because I think that there's also some silver linings here and there around this really dark cloud. But what actually happens is you have. I had to get a history lesson of how we got here, and you really can't understand what is the problem with Obamacare and why it even exists unless you have a knowledge of how we got there. Now, there's no question, absolutely no question, that there is a major serious problem with our healthcare system, and there was before Obamacare was passed. But it wasn't the healthcare system itself, because if you say there's a problem with the healthcare system, you're saying there's a problem with me as a doctor. There's a problem with our nurses. There's a problem with our hospitals. And all of us know, whether we listen to skewed data that says otherwise or not, that we have the best healthcare system in the world, and the best doctors, and the best hospitals, and the most advanced technology. The problem is that we have a major problem with healthcare financing, and that's really the problem. And this goes back. This didn't start with President Obama's election. It didn't even start with President Clinton's election. It didn't even start with Ronald Reagan. This goes way back. This goes way back to the 20s and the 30s. And one of the most major events in starting the snowball slowly rolling up from the top of the mountain was FDR. And under Roosevelt, he created the idea of fringe benefits, where he froze employees' salaries. And so to entice employees where there was a labor shortage because of World War II, companies were allowed to offer and pay for on a pre-tax basis health insurance. And that was called a fringe benefits because it was outside, it was in the fringe of compensation. And so what he created was an employer incentivized health insurance system. And so it did several things. One is it tied the employee to the employer and sort of enslaved them into the employer if they actually had a medical issue. So if you had that pre-existing condition or if you had health problems, you didn't change jobs because you would lose your insurance. And so the other thing it did is it created lack of portability. The insurance didn't belong to the individual employee, didn't belong to the person. It actually belonged to the employer. And so there was no portability. It also meant that as an individual, if you wanted to purchase health insurance, you didn't have the same tax incentive. So as an individual, you have to buy it with post-tax dollars, which is more expensive. And that was not fair. And then healthcare reform was pretty quiet for a long time until 1962, when President Kennedy tried to pass Medicare. And at the time, the American Medical Association was against it. And the American Medical Association represented well over 50% of doctors at the time. And they blocked Medicare twice, in 1962 and in 1963. And in 1965, the AMA caved in, and Medicare was created. And the very first benchmark of cost for Medicare, the reality was that it cost 10 times as much as they predicted it would cost by 1980. And so Medicare was really the beginning of socialized healthcare system. Because if you're 65, let's take it back. If you're 63, and suppose you have an insurance policy, and you purchase it on your own and get it from wherever, Blue Cross Blue Shield of Texas, and it might cost you $400 a month, $500 a month. So when you turn 64, it might cost you $425 a month. When you're 65, it's not offered. You can't buy it. And it's not because it's illegal for you to buy. It's because everybody goes on Medicare and is eligible for Medicare. So there is no market because there's no population of patients at that age group and above. So when you turn 65, you really don't have a choice if you're an individual because it's almost impossible to buy health insurance because it's not offered. It doesn't exist. There is no market because the federal government has created a socialized system starting at age 65. And then the great Ronald Reagan was the next person to really affect the healthcare system. And what happened under Ronald Reagan was really what started to exponentially bring us to the point where we stood today and where we stood 5 years ago when Obamacare was passed, was being pushed through. Under Ronald Reagan in 1983, prior to that, when a patient went to the doctor, the patient paid the doctor, they paid the hospital, they paid the lab. Then they turn around and send a claim form to their insurance company to get reimbursed for their loss, just like you do with car insurance and flood insurance and whatever other insurances. And what happened was that in 1983, it was called HCFA at the time. It's now called CMS. It was the part of the government that runs Medicare and Medicaid. It pushed through these regulations where if you are a Medicare patient and if the physician's a Medicare provider, then the physician had to do three things. One is he had to take the Medicare fee schedule. It didn't matter what he charged or what the hospital charged. The government set the price. And the physician or the hospital were not allowed to balance bill the patient. They had to take that fee as the maximum fee. The second thing that happened is the provider had to bill on behalf of the patient. The patient never saw the charges since then. The patient never saw the charges, never saw the billing. They were blinded to what was happening. So as if the physician was required to bill on behalf of the patient and send that bill to the insurance company directly. And then the last thing is that the patient and the physician were obligated to collect copays and coinsurances. So at the time, for example, if you were a Medicare provider, you were a doctor and you had an older person who didn't have any means and Medicare only covered 80% of their bills, it meant that 20% you couldn't be charitable and say, you know what, I don't have to collect that from you. You know, I made enough money off of you, whatever. I don't have to collect that from you. Let me be charitable. If you do that, that's called Medicare fraud. And the reason it's Medicare fraud is because you discriminated and you didn't follow the rules. So as a provider, you have to collect coinsurances and copays and deductibles. And the patient, by law, is obligated to pay those. So what happens is it removed charity from healthcare system. Within a year, all the private insurance companies learned very, very quickly about the third-party payer system. And every insurance contract I've had with every company, and including private companies and smaller companies, has three pillars that support it. One is they set the fees. Number two, they require the physician to do the billing on behalf of the patient, so the patient is blinded from what is happening. And number three is you had to collect the deductibles and coinsurances because that was the mechanism of cost control. And they did studies on this. If the patient had no copay, they went to the doctor many, many times. If they had a small copay, they went to the doctor less. If they had a big copay, they really didn't go to the doctor at all. So that was the cost control mechanism. And so under Ronald Reagan, we created the third-party payer system. And if you look at the cost of health care that was rising up until 1983, in 1983, it took a straight skyrocketing to that cost curve. And it's never had even a small down bleep ever since. And that was really the problem, is that in 1983, the paying for health care was no longer tied to the individual patient. So the patient no longer made decisions, financial decisions, of what treatment I do get, what treatment I don't get. It was do everything. And they didn't, and the doctor, because the physician really doesn't know what tests cost, even though they should, they usually don't. They don't know what a CAT scan costs, what an MRI costs, because they're blinded from that too. Because the facility has a contract with the insurance company or Medicare or whatever, and those fees the physician doesn't know about. So when a patient comes to me and says, what is this procedure going to cost me? I say, I don't know. What do you mean you don't know? I can tell you what my fees, but that's irrelevant. When they process the claims, they're going to tell me what you owe me. But that's really, remember, that's only 12% of the pie or less. So I don't know how much the hospital or the surgery center or whatever is going to charge. I don't know what anesthesia is going to charge. I don't know what pathology is going to charge. I'm blinded from that. So starting in 1983, there was no transparency of the healthcare system. So nobody knows what anything costs until after the fact. And so all rules of economics have been suspended in healthcare. And this is going back a long, 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 long time. And then the system sort of went out of control, but the economics were pretty good in the 1980s and 1990s as a result of Reagan's better policies. And so this was sort of put out in the back burner until HillaryCare came along. And that was defeated by a grassroots organization of physicians called the AAPS. I belong to them too. They're a good group. And they've won some good legal battles. And then HillaryCare was shelved in the early 1990s. And it sat on the shelf for about 20 years. And it resurfaced. And so what is ObamaCare? People call it ObamaCare and they give President Obama credit. He doesn't deserve any credit. All he did was sign the law. He pushed it. He strong-armed people into going on board. He convinced people that were so far on the left that they swore they would never they would never vote for ObamaCare because it didn't have a public option. It wasn't socialist enough. People like Dennis Kucinich. I know him because he was mayor of Cleveland, where I grew up. And after he bankrupted the city of Cleveland, they rewarded him by sending him to Congress for over 20 years to represent them. So Dennis Kucinich there's a video of Dennis Kucinich vowing to not vote for this law because it didn't have a public option. And he basically swore and vowed that he would never vote for this law. Then he went on Air Force One for a little trip, and then he voted for it. So President Obama strong-armed people into signing up for it, but he never knew what was in it. He never wrote anything in it because that law sat on the shelf for over 20 years in some back room. And you know, Nancy Pelosi, Harry Reid, and President Obama just basically pushed the agenda through. It wasn't their agenda. Somebody else wrote it. And it was flawed. And there's lots of flaws in this law. And the reason there's lots of flaws in it is because it never really saw the light of day where people could analyze it and scrutinize it. And that was by design. But the real reason is because they don't really care what's in the law. Because that's not the goal. If you look at certain things that are in the law, the goal is really a single-payer healthcare system. The goal is socialized medicine. And the law is designed to implode the insurance industry. They've already, in the law, is an 80% medical loss ratio, which means that of every dollar that the insurance company collects, they have to spend 80 cents on direct patient care. And whatever they don't, they have to refund to whoever paid the premium. Okay? And I actually got a refund check last year from Blue Cross Blue Shield because they didn't spend all the 80%. Then the insurance companies, out of that 20%, they have to pay all their administrative costs, all their stockholders, and whatever else. Now, you're like, well, but you know, they're the big evil insurance companies. They signed up for Obamacare. They supported it. Well, why is this bad? Well, the reason it's bad is because if you look at other insurance-type programs, like car insurance, their loss ratio is much lower than that. Why do you think there's so many ads for Geico and Esurance and all these other car insurance companies all the time? Because they make a tremendous amount of money because their loss ratio is 70% or lower. So health insurance is not going to be a good business model. And what happens is that Obamacare actually has a built-in a built-in rescue program, a built-in rescue package for the insurance industry that doesn't have to go through Congress because it's already built in. So if an insurance company goes under, all the president has to do is bail it out. There's a built-in bailout. But what if he doesn't bail them out? Lets them go under. Then there will be a cry for, we need insurance. And I'm sure the federal government's going to be just more than happy to come in and insure everybody. But they're not going to do Medicare for all. It's too expensive. They're going to do Medicaid for all, which is also expensive. And that's really the problem. So the problem is that this law is designed to destroy the insurance industry. And if you look at everything that's happened, if you look at the new sign-ups for ObamaCare, who's signing up? The people who are sick, the people who have pre-existing conditions, the people who already have cancers. One of my patients signed up for ObamaCare, and she has advanced metastatic bladder cancer. She's going to start chemo in the next month after she recovers from the huge operation I did on her. So, and I hope she does well. But, ObamaCare delayed her getting care by at least a month because they couldn't verify, Blue Cross couldn't verify that she had actually paid because she paid through the website. So because they couldn't verify it, no hospital could verify her benefits, and so she couldn't have the procedure until February because her insurance didn't kick in because they couldn't verify even though she paid in December. So, but that's not the issue. The issue is that for ObamaCare to work, young, healthy people have to go in, sign up, and pay a lot more than they would have had to pay before ObamaCare or even before last year. So, because they're supposed to subsidize all these people, well, the young people already figured it out. We're young and healthy. The penalty, or as Judge Roberts called the tax, is not very significant. And plus, they can't really go after you for it. They can only take it out of your return and your refund. So they're not signing up. And so the insurance companies are having to pay for the sicker patients that are requiring utilization, but they're not getting the money from the healthy patients that are not going to require utilization. And so the insurance companies in the United States right now are undergoing a death spiral. They're not so worried because there's a bailout. But what if the bailout doesn't actually occur? That's what my wife brought to my attention. I said, yeah, they'll be bailed out. She told me, wait, what if they don't get bailed out? What if they just let them go under? And that's very, very serious because there's some states, like I forgot if it's Alabama or Mississippi, where in the private insurance market, over 90% of the state is covered by Blue Cross Blue Shield, by one insurance company. If that one insurance company goes under, literally the entire state will have no private health insurance. And that's really, really, really scary. So, that was terrible, and now that everybody's completely depressed. What are there alternatives? What is really happening? What's really happening is that there is a thriving and growing, it's very small, free enterprise system in healthcare right now. Because there's all kinds of end-arounds that still exist. For example, I'll give you just one example. There's 3 family practice physicians in Wichita, Kansas, who started a practice, a medical practice, and they call it Atlas MD. You can go to atlasmd.com, I think. And Atlas after Ayn Rand's book, Atlas Shrugged. So what they did was smaller employers and even larger employers that self-insure fall under ERISA, which is a law that sort of is excluded from ObamaCare. So those employers don't have to follow all the same rules under ObamaCare. They have plenty of their own rules to follow. But what happens is they can self-insure, they can decide what they want to do with deductibles and that sort of thing. So this group of doctors went to some employers and put together concierge medicine, but not for the wealthy, where they pay the doctor $1,800, $1,500, $2,000 a year to have a doctor at their beck and call. They're doing kind of a concierge medicine for the average person, for the average worker. So, for example, there's if there's a small business that has 50, 100 employees, something like that, then this group would tell the employer, okay, get a catastrophic plan that covers everything with like a $10,000 deductible in case somebody really gets sick, needs surgery, has something like that, and pay us a monthly fee for each patient. Okay, and that monthly fee is like $50 a month for an adult, $10 a month for a kid. Prepaid. And we'll take care of all their primary care needs. No deductibles, no coinsurances, no nothing. It's going to be a cash business, though. So what this group also did was they created an electronic medical records for cash practice. An electronic medical record, not like the one I have in my office that has all the bullet points that the federal government wants, from ethnicity to national origin to preferred language. And Old English is one of those choices. And Gaelic is one of those choices. And Aramaic is even on that list. I mean, there's over 2,000 languages you can choose from. But they created their own thing. And their patients get their cell phones and their emails. And so, for example, if the worker in the middle of the day thinks he might have the flu or he might be sick, he doesn't have to take the day off. He doesn't have to take half a day off. He doesn't have to go sit in a doctor's office. He texts the doctor. This is what I'm feeling. What should I do? The doctor texts him back, emails him back, and says, try this, try that. The employer's happy because the employee is at work. The employee's happy because he didn't lose the money for having to go see the doctor. The doctor took care of the patient. And all those patients are having physicals, school physicals, annual physicals. And what happens is those physicians are using the free enterprise system for testing for the patient as well. So they got the cost of doing an EKG down to 31 cents. They negotiated with the labs. So if the patient needs a CBC, a complete blood count, to see if they're anemic or not, it costs $1.50. The patients kind of like that. They prefer $1.50 over like $100 for some of those tests. And those patients are getting the tests. They're getting in the free enterprise system because the real costs of doing things are very low if you do it. Because if you eliminate the regulators and the insurers and just go between the patient and the doctor, between the employer and the doctor, eliminate all this other stuff, you save a lot of money. And you can pass those savings on. So if one of those patients has some abdominal pains, they already know that they're not going to go to the emergency room because it might cost them more. So they'll call their doctor, and as long as they're not truly dying, the doctor will see them, and they'll order a CAT scan as an outpatient, and they've got it negotiated down. They can do an abdominal CAT scan for $200. If you go to the emergency room, that costs you $2,000. They can get it done for $200. And if it's really negative, you saved yourself a $3,000-$4,000 emergency room visit. And the employers love that. And what happens is from year to year, their cost of health care goes down. It is absolutely amazing what can happen there in the free market if you just eliminate all these things in the background. And people are doing it. There's a group in Florida called Epiphany Health. There's a dermatologist I know in the People's Republic of Oregon that has a cash practice. She bills by time. She has no CPT codes. She doesn't use those codes the AMA has royalties on that makes them about $60 to $100 million a year, and that's why they're a pawn of the government. Remember I told you the AMA used to represent over 50% of doctors, 75% of doctors? When ObamaCare passed, they represented about 17% of doctors, and now it's less than 10%. But they can do that because they make $60 to $80 million a year from royalties from the coding system. And those codes are a government-protected monopoly that goes back to Ronald Reagan in 1983 and those regulations. So there's definitely a silver lining. And he said, well, man, if the Republicans can only block this, if the Republicans can only block that, well, people say, well, the Republicans have no plan. Well, they have a plan. They have a plan because we put a plan in their hands. So 8 of us from Docs for Patient Care met with Speaker Boehner in April of 2010. And we put a prescription in his hand. That's what we do. We write prescriptions. The prescription was revised this year. We give him an 8-point plan. This talks about a 9-point plan of if you do this with the healthcare system, you will fix everything. You will fix everything. And let me close with this. Why did ObamaCare pass? Here, let me pass this out. Why did It passed because there was an emergency. There was an emergency. We had 47 million Americans without health insurance. Not health care, health insurance. And then those numbers started, moving. Then suddenly they realized that 17 million were illegal aliens. And so that became 30 million. So then they talked about 30 million Americans. And then that was the number. But the real reality is that half of those people could already get health insurance. Over half of those people could already get health insurance. What happened was that a large portion of those people already qualified for Medicare or Medicaid or other programs. And then there was a huge proportion, the majority of those people, they're called invincibles in the insurance industry. What invincibles are people who are young and healthy in their 20s and 30s. And those people, on average, made over $75,000 a year and could afford to buy health insurance. They just chose not to, because they'd rather buy the iPhone and the iPad and go to the gym and go on trips or whatever. They chose not to buy health insurance. And when they got sick or got the flu, they went to the doctor and they paid money and that they had. But they just didn't have insurance. And so those weren't people that couldn't get insurance. But then there was a small segment of the population, less than 5% of the population, very small segment that has basically been constant with time. The numbers were people shift in and out of that group, and that's the working poor, that they don't qualify for health insurance. They don't qualify for Medicaid and government programs because they make just a little too much, but they can't afford health insurance because it's ridiculously expensive. And it's ridiculously expensive because of all the government regulations and state regulations. It's not just federal government. Every state has unbelievable number of mandates for the insurance industry that also add cost. And then there were the people with pre-existing conditions. And if you listen to speeches, you'd think that like every other person in the room has a pre-existing condition. And the reality is that's not true. There's only a few million people that actually have pre-existing conditions. And these are terrible conditions. These are people who have already had a cancer, or they're older people who already have diabetes but don't qualify for Medicare, and so no insurer would touch them. Or they're people who might have multiple sclerosis or some other horrible disease. And those are people that really needed help, the working poor and the people with pre-existing conditions. So what happened was we turned over the entire healthcare system to the government, and a fifth of our economy, and $2.6 trillion industry, or actually larger than that now, in order to help 5%. Couldn't we just have helped the 5%? Give them sort of subsidies to help them buy insurance in the free market, and if they needed to, or there were already high-risk pools set up in Texas. I have a friend who has a lot of medical issues, and she couldn't be on her husband's insurance, and so she was in the Texas high-risk pool. And what happened was that starting this year, she had to go to ObamaCare because the Texas high-risk pool was dismantled. It was dismantled because it was no longer needed because of ObamaCare. So Texas was already taking care of some of these patients by creating a high-risk insurance pool. And other states were doing the same, and that went away. So the reality is we turned over the entire healthcare industry and created horror stories, unbelievable horror stories, and in order to just help less than 5% of the population who needed help. And as a society, we should have been helping them. But we sort of picked the wrong way to do it. All right. Any questions?
Can you explain what a single-payer system is? I mean, I keep hearing this term, but I don't really understand what that is and how Obamacare relates to that. And
okay, Obamacare is not a single-payer system. Obamacare is a regulatory mechanism, and then it's a mechanism to redistribute money to allow people to purchase insurance in the free marketplace. Okay, and Obamacare is a mandate that individual people must purchase health insurance by the virtue of existing, living and breathing. They're required to purchase a health insurance program that has certain features that are predictated from a private entity. Okay, it basically means that whether you need to or not, Robbie, your insurance plan must cover hysterectomy. Okay, whether you're going to have a hysterectomy or not, I'm assuming you're not in the near future, you pay for it. It's in your plan. So that crazy things like that a woman who would be 55 or 56 her insurance policy has to cover prenatal care in case she gets pregnant. So that's crazy. So it does not allow intelligence, and it does not allow freedom of choice. Okay, but that's not what a single-payer system is. That's what ObamaCare is. A single-payer system is where the government is the single payer for healthcare services in a country, and that's what Canada has. And it means in Canada is everybody has insurance. Everybody's got a card. And the only problem is that when you have that, you have insurance, but you don't have access to care. So my brother-in-law's brother-in-law is Canadian. And one of his friends finished residency in Canada as an ENT, an ear, nose, and throat surgeon. And a couple of years ago. And that friend was one of 4 ENTs entering the practice of medicine in Canada for the year. So the country of Canada added 4 ENTs in 1 year. So if you've got a head and neck tumor and you might have throat cancer, how long is it going to take you to see an ENT? If only 4 new ones came out that year. Who knows how many retired that year? Hopefully it was less than 4. This is for the entire country of Canada. That's insane. So what happens in Canada is if you have chest pains, but you haven't keeled over yet, and you're not in an emergency room, you need, a heart workup. You may need a heart catheterization. It might take you months to get that. And if you survive that wait, you might need a heart bypass. And it might take you 6 to 9 to 12 months to get to that heart surgeon, to get to that operating table. So I grew up in Cleveland, where there's the Cleveland Clinic, the number 1 heart center in the world. Number 2 and 3 are in Houston. And so people from Canada were mortgaging their house, coming across Lake Erie, or around Lake Erie, and getting their heart bypass for cash at the Cleveland Clinic. 20, 30 grand, and they'd get their heart bypass and live and then go back to Canada and try to pay off their debts. So they were literally they were escaping Canada to have their surgeries done in the United States for cash. So that's what happens in a single-payer healthcare system. Single-payer healthcare system is why we didn't return to Israel after my father finished his fellowship after his post-residency training, because the resources are limited. So, and then what happens is you get corruptibility. I'll give you an example. In urology, suppose you can't pee because you've got a big prostate and it blocks your bladder. So you're walking around with a catheter. But you're not a real emergency. You just have a catheter you're walking around with, which is not pleasant. So you might be 6, 12 months on a waiting list getting your catheter changed every month while you wait for your prostate surgery. But if the family pays the head of the department under the table cash, your surgery might be next week. So whenever you put restrictions and rationing and things like that, you allow for corruptibility and an underground economy, which is bad and not fair. And so in Canada, it is actually illegal. And 2 provinces actually just made it legal, but as a general rule, it is illegal in Canada for you to seek care outside of Canadian Medicare. So it's illegal for you to say, wow, maybe I'll just go to the doctor and pay them directly and he'll see me today. That's illegal. That is a crime. So a single-payer healthcare system, which is what they have in Canada, which is what they have in England, which is what they have in most modern industrialist countries, is the government runs healthcare. And the people don't have to pay for it, or they have to pay very little for it. But in exchange, they wait. And they don't have the same type of quality. And the reality is, if you have prostate cancer in the United States, you have a certain cure rate. That cure rate is a third of our cure rate in England. So the reality is, if you get prostate cancer in England, you have a good probability of dying from it, where you would be saved in the United States. Same thing holds true for breast cancer. So they have a tenth as many colonoscopies in Canada. The rate of colonoscopy for the population is a tenth in Canada what it is in the United States. What does that mean? That means that people are dying from colon cancer because they're not catching polyps. That's what that means. So that's what a single-payer healthcare system is, where all the dollars are controlled by a single entity, which is the government. And then they restrict everything. And that's the goal. That is the ultimate goal. President Obama has said it in many speeches going back 20 years.
Example of socialized medicine from Britain. From the age of 5 to 13, I split my neck open, and it took 5 operations on my neck from doctors nobody knew about, and they didn't know what they were doing. I'm an example of socialized medicine. And I think that came from what we're getting now. I think it's transferring to America, socialized medicine.
I agree with you. And the person who was in charge of Medicare when ObamaCare came through, his name was Donald Berwick. And Donald Berwick has a love affair with the NHS, with the British healthcare system. He thinks the problem is not rationing. The problem is you have to ration with your eyes open, and you have to ration more aggressively in order to make the healthcare system work. That's what he believed. And you're right. It's not the right way to treat people.
When all of this came up about needing Obamacare because of the emergency of all these people that don't have insurance, the ones that couldn't afford it, the poor that needed it and all that, I mean, we could have just paid for something for them for, what, a few $1 billion or something, rather than a big thing that covers, regulates everything. I mean, we could have given them the money. We could
Absolutely.
pay them for a lot less than what this is.
For a tiny, tiny, tiny fraction. Yeah. Absolutely.
You spoke of the free enterprise system that is starting to develop that comes here. How long do you think it will be before the federal government simply makes that illegal?
It's interesting. The federal government wants to make that illegal. The problem is that the state of Massachusetts tried to tie medical licenses to accepting Medicaid because the state of Massachusetts did ObamaCare. And ObamaCare was a disaster. And ObamaCare told you what was going to happen under ObamaCare. ObamaCare was Obamacare light. And ObamaCare worked great, except that it needed to be bailed out by the federal government at least 3 times. It meant that your wait to see a doctor went up to 47 days. So if you had the flu, by the time you got in to see your doctor, your flu was long gone. It meant that what happened under ObamaCare is patients with diabetes or high blood pressure or whatever were having group doctor visits, where like 10 patients would get in a room with a doctor. And then all the diabetics would talk about how they controlled, kind of like an AA meeting. But the difference is, diabetes, for example, causes some personal things like impotence is one of the leading causes is diabetes of problems with erections. How are you going to talk to your doctor about that in front of 10 other people? So they were doing group visits in Massachusetts. And what they tried to do in Massachusetts was they tried to tie licensure. Because for now, licensing of physicians is on a state-by-state basis. So I can't call in a prescription in Louisiana because I'm licensed only in Texas. So there have been pushes, and that measure in Massachusetts was narrowly defeated. They almost tied it to licensure. And doctors were already fleeing Massachusetts, after ObamaCare started. And so there are people that want a national medical license because that will allow them to more easily control and force a doctor to be on Medicaid or Medicare or make it illegal for them to do a free enterprise system. And you're right. I mean, that is, in some states, that is already a target of targeting, preventing people from going outside the system, which is exactly what Canada did. In Canada, 2 provinces actually relaxed a little bit and allow a little bit of private practice of medicine now. But that had to do with many, many lawsuits of people who came to the United States, got care, and then went back to Canada and sued to get their money back, saying that the Canadian system wasn't treating them. So, but you're right, it's in the crosshairs.
To piggyback on that, have you considered moving to that system yourself?
I've always seen patients for cash. In addition to everything else, I'm a urologist, so I take care of a lot of seniors. So I take care of Medicare patients, take care of Medicare Advantage patients, I take care of HMOs. Up until 2 years ago, I was the only doctor the only urologist willing to take new Medicaid patients on some plans in the entire Houston area. I had to stop doing that because I felt I was doing more than my share. I kind of thought of it as my charity because I actually lost money. I would actually pay to see those patients because the amount of money I was getting back from Medicaid for seeing those patients didn't even cover my employees' salaries, let alone take anything home for my family. And so I stopped seeing new Medicaid patients 2 years ago, but I still see my older ones. And occasionally I'll see one in the hospital as an emergency, but I won't fully reject them because I think we have to take care of the poor and the disabled. I mean that's part of what we do as physicians. And but I've always seen cash patients. I've never rejected somebody because he didn't have insurance. As a matter of fact, there's lots. I could tell you, there's a physician I know brought over his family from Egypt to see somebody in the medical center for bladder cancer. And the amount of money that for an outpatient endoscopic surgery just to diagnose the cancer, I could tell you one of the hospitals in the medical center wanted like $30,000 for a day surgery. It's outrageous. And so you find that many people will gouge the cash patient. They'll say, I'll give you a discount of 10% off my fees or whatever, but the fees were already ridiculous. So my philosophy was always, if I'm willing to take Medicare rates for Medicare, I'll do Medicare rates for my cash patients. And but then it actually is better for me because I don't have all the administrative costs because cash is cash, and I save them a lot of money, far more than anybody else is going to charge them. So I thought that was always fair. If I'm willing to take care of Medicare patients for Medicare rates, why would I take care of somebody who's paying cash for more? I don't think it's fair to the person. So I've always taken cash patients. And I'll tell you an interesting story. When I opened my first office in Pasadena, I'm no longer in that office. We've since moved. On the first floor of the professional building were two physicians. And they used to see patients for cash. And they had signs. Office visit, $15. Cash. Not kidding. It's actually gone up in the last 15 years. It's now $27. And one of those two doctors has died from prostate cancer and passed on. So the other one's still doing that practice. So you have patients who actually have insurance. And patients don't have insurance. But patients who have insurance, where their copay might be $40 or $30 or $50 now, because copays have gone up to decrease utilization, to prevent patients from utilizing the system because they're expensive. And so the patients with insurance would actually go to this doctor. Suppose they had a cold or a flu or whatever. They go to the office there. They get a prescription. They think they have a urinary tract infection, whatever. The doctor sees them, does a very basic test, charges them $27, and they're gone. And they're happy. And this physician has been doing, these physicians have been doing this in Pasadena, over in that office building for 30 years. They've been seeing patients for cash. But how could they possibly do it? Well, because they have no overhead. It's like you come and you pay, and the doctor has no overhead. He doesn't have to keep an electronic medical record. It costs tens of thousands of dollars. He doesn't have to, he has, he's not taking care of the patient if they go to the hospital or whatever. But, most things don't end up in an emergency room or an operating room. Most things can be handled simply. I mean, this is not screening. This is basically when they get ill. So the cash practice of medicine actually works and works very well. And I've always had a little bit of cash practice. There's just not that much in existence. And but it exists. And what you're seeing now is that's actually people are being forced into that system. I'll give you an example. I've always provided health insurance for my employees. And most doctors' offices, small doctors' offices, do not. It's just too expensive. So I've always been, I've always eaten it. And I thought that's what I need to do for my employees. It's the right thing to do, that my employees have access to health insurance. And it's very expensive. And since ObamaCare passed, it's double. It's almost $500 a month per employee. And they pay 10 or 20% of it out of their paychecks. And so our renewal is March 1st. And so this week, I got our renewal for our plan. And I've renewed the same Aetna HMO for a long time. It's a good plan for my employees because they just have a copay. And their deductible is like their max amount of pocket is like $1,500 or something. It's a great plan, like 10 times better than what I have for my family. And so starting this year, I got the notice that that plan is no longer going to be available because they're complying with the law, with ObamaCare. And now actually what's going to happen is my premiums are going to go down. I'm going to save money on my health insurance. Why? Because of community rating. Because most of my employees were female. And I've got 2 male employees. But now ObamaCare doesn't discriminate for the individual. So an insurance policy can't charge me more money because I have an extra 20 pounds around my belly. They have to charge me whatever they charge the community as a whole. There's community rating. So what happens is it's as if half of my employees are now male. So my rates go down because health insurance for young males is less than health insurance for young females because males don't get pregnant. So, and they don't utilize the doctor as much. So my health insurance costs are actually going down. But my employees are absolutely screwed. Because what's happening now is that they have to comply with ObamaCare. So they're getting now a $6,000 out-of-pocket individual, $12,700 out-of-pocket family maximum. Their deductibles are going through the roof. So even though I chose a plan, not the cheapest, chose a plan where they still can have copays for drugs and still have copays for doctor visits as opposed to like HSA type things where a lot of my employees just couldn't afford that. And I want them to be able to get care if they need to. The deal is if they actually need to go to the hospital, if they actually have a surgery, if they actually get pregnant and have a child, they're going to have $6,000 to pay for. And so I can't even offer them the plan that they had, which was much better than that, because of ObamaCare. So what happens with people like this is that they're going to be forced into a cash market. Because there is, for example, a surgery center in Oklahoma, and this is kind of like the poster child, that was started by 2 anesthesiologists, and it's called Surgery Center of Oklahoma. It's in Oklahoma City. And they have a cash business, package deals. You know, a hernia costs this much. Hernia with mesh, they have a set fee. This is the fee, this is what it's going to cost you. It's going to cover the surgeon, the anesthesiologist, the facility, etc. And they practice very high level of care. And they have the same doctors work there that work in the hospitals around the same city. And what happens is even the state of Alaska, if their employees need a hernia or something, they'll put them on a plane, they'll fly them to Oklahoma City, they'll put them up in a hotel, have them have the surgery there, have them recover there for a few days in a hotel, fly them back to Alaska because it's cheaper. So when a patient comes to one of the hospitals in Oklahoma City and says, how much is it going to cost me to fix my hernia? Well, you know what they do? The hospital goes to the website of Surgery Center of Oklahoma and tells them what the price is and matches the price, or else they'll lose the business. And so it is purely free enterprise. They don't take Medicare or whatever. So there's patients that might have a $6,000 deductible, and they need a hernia, and if that hernia only costs $2,000 or $3,000 to fix, they'll do the math, and they'll say, you know what? I'm young, I'm healthy, I don't have any other problems. I'm going to do it for cash and save money. So the reality is that these crazy deductibles and out-of-pocket maximums are literally forcing people to seek cash alternatives. And the only problem, what happens is suppose somebody has insurance and I know they have insurance. And they come to me and they want me to do it for cash. If I know they have insurance, I would be violating my insurance contract as a provider. Do you see what the problem here is? So they would almost have to come and tell me, I don't have insurance, or I have no insurance. And I would have to make sure my staff doesn't verify that they don't have insurance. And then I can treat them, because then I didn't know they had insurance.
You're required by law to ask?
No, not yet. So the reality is you're going to see games being played very soon. But literally, patients are being forced to seek alternatives because the deductibles are crazy.
Cash dental program called Dentex.
Yeah.
We dump the insurance, and it saves a lot on root canals and things like that.
I'm sure you're right.
Well, the lion's share of the funding of the Affordable Care Act was lifted directly out of Medicare.
Yes.
What do you see as the long-term impact on Medicare as a result of that?
It's a disaster. Because originally they said $560 billion, and the latest number was $716 billion. Well, Medicare, before Obamacare, was already going to be bankrupt by 2019. But that was without Obamacare. Because the reality with Medicare was set up as an insurance company, but they didn't run it like an insurance company. So when they passed Medicare in 1965, only 2% of the people made it to 65. And so for every person on Medicare, there were over 15 employees paying into Medicare. Well, that number has gone way, way down. So basically, it is an unbelievable Ponzi scheme. And we have 10,000 Americans aging into Medicare every day. Every day. The baby boomers are now becoming all Medicare age group. And it is an absolute disaster because the funds are not there. The funds weren't there to start with, and then Obamacare stole all this money to cover non-Medicare patients, which means the money that I'm paying into Medicare, the money you're paying into Medicare as part of your Medicare tax as an employee, or now the money you're paying into Medicare as capital gains, 3.8% of capital gains if you make a certain amount of income, and that sort of thing. There are all these added new Medicare taxes. That money that's going to fund Medicare is being funneled to cover non-Medicare patients, which is completely wrong. And what's going to happen is active rationing. And this is what Sarah Palin was chastised, and because she said there's a death panel in Obamacare. And she was talking about the IPAB, the Independent Payment Advisory Board. It's a group of unaccountable for people that are appointed, that have the unilateral power to set fees to decide what Medicare pays for and what they don't, with no place to appeal it. And the only way their decisions can be overridden is by a 2/3 majority of Congress. And there's only one thing Congress agreed. There's only two things Congress votes by more than 2/3 about: their own pay raises and benefits, and Israel. That's it. Those are the only two things they do. Okay, everything else, it's very narrow votes. So the IPAB is the rationing board, and it applies to Medicare specifically. It doesn't apply to Blue Cross patients or private patients. It applies to Medicare. But Sarah Palin, when she said there was a death panel in Obamacare, she was completely 100% wrong. There's at least 2 death panels in Obamacare, because the other death panel is called the U.S. Preventive Services Task Force. It's not part of Obamacare, but Obamacare refers to it multiple times. And the U.S. Preventive Services Task Force is a group of appointed, unaccounted for physicians who sit on a board, and they determine what is and isn't preventative health services. And that's important, because under Obamacare, preventative health services is covered at 100% without deductible and coinsurance, such as birth control. That's a preventive health service they defined. So therefore, every insurance plan has to cover for contraception, whatever, at the abortion pill, anything you want, at 100% without deductible and coinsurance, because it's preventive health service. Okay, regardless of what your religious beliefs are, it's irrelevant. It's in the law. Preventive health services are covered at 100%. So if colonoscopy is a preventive health service, the patient, it should be covered at 100% without co-deductible and coinsurance. Now, here's the problem. What is a preventive health service? Well, the U.S. Preventive Services Task Force are these physicians determine what is and isn't preventive health and what isn't proper screening. So a number of years ago, that panel got together and looked at breast cancer and determined that they're going to ignore what the American Cancer Society says and what all those people that wear pink ribbons say. And they decided that women should have a mammogram between the ages of 50 and 70. And that's okay, because none of us know anybody who had breast cancer under age 50. So only between the ages of 50 and 70. Again, nobody dies from breast cancer after age 70, so we'll let those people die. And then only once every 2 years, because no breast cancer can grow from 2 years to 2 years, for year to year, so might as well just do it every 2 years. It was a financial decision, okay? And as a matter of fact, one of my sister's friends just recently died from metastatic breast cancer at the age of 42, leaving a husband and 3 kids. So she would not be screened under these criteria. And the electronic medical records, remember I talked about them in the beginning? They prompt the doctor to remind the doctor to order certain screening tests. And they prompt the doctor to order a mammogram only between the ages of 50 and 70 and only every 2 years. So it's already implemented into the electronic medical record. That's not even Obamacare. But I'll get back to Obamacare. So there was a big, big outcry by the breast cancer groups because they're like militant. Women really protect their breasts. That group is unbelievable. I mean, everybody in the federal government is terrified of these people. So they sort of backed off. They didn't change the recommendation. The electronic medical records still follow the recommendation, but they sort of backed off on implementing it publicly. So this group about 2 years ago tackled prostate cancer, and they looked at the literature of prostate cancer. They evaluated the literature. They read peer-reviewed articles, and they came up with certain criteria. And they said the PSA test, the one that finds prostate cancer, it's dangerous. They gave it a grade of a D. It's a bad test. It causes more harm than good because it's a blood test. It causes more harm than good because it causes screening and biopsies and complications and the surgeries have complications, etc. Okay. So when I went into practice in 1998, 48,000 Americans were dying every year from prostate cancer. This is with PSA testing, with surgery and everything. Today, only 28,000 Americans die from prostate cancer. And Americans live longer. Does prostate cancer just go away? No. We treat prostate cancer, we catch it early, and we cure people. So people die from something else. I still have people die from prostate cancer. But they're very few, far and few between. Few and far between. So what did this panel decide about prostate cancer? They decided it's a harmful test. And they gave it a grade of a D. So if you are an Obamacare administrator, you said, well, the PSA is a harmful test. It's not going to be preventive health services. We're not paying for it. So if we don't pay for it, we don't get tested. We don't get it tested, we're going to be like Sweden. What happens in Sweden? All the studies of what happens with prostate cancer untreated comes from Sweden because they don't do PSA tests. Because those are old people. They're going to die from something anyway. Let them die from prostate cancer. So they don't treat prostate cancer in Sweden. They wait until it's metastatic disease, and then they do some palliative care, and that's it. Morphine's cheaper than chemotherapy, radiation, and surgery. So let's get back to this panel that made this recommendation. They're all doctors. So how many urologists that treat prostate cancer every day? 0. How many oncologists, how many cancer doctors that don't treat prostate cancer but at least know about it? 0. How many radiation oncologists? 0. And the head of the panel is a very distinguished pediatrician from Texas Children's Hospital. And I know she doesn't treat a lot of prostate cancer at Texas Children's. This is the group of physicians that made the recommendations of whether or not somebody should have PSA testing in America. They're physicians, but they're not experts on prostate cancer. And to add insult to insult, is they made the announcement on the Monday after 5, in other words, after the close of business, during the time that the American Urological Association was meeting in Atlanta. I was in Atlanta when they made the final announcement that basically says PSA test is harmful. At the same time that the 14,000 urologists in this country are meeting in Atlanta to discuss, and what are they presenting? They're talking about, the prostate cancer death rate going down because of all treatments and all that sort of stuff. And during the same time, they're talking about, they're announcing that PSA testing is dangerous. There's an adage, there's a terrible book, a really horrific book that every resident reads. It's called The House of God. It's really terrible, and it talks about the inappropriate comments, inappropriate names, inappropriate treatment of patients that goes back to the 1970s. And the really sick thing about this is it's really true. So every resident, every medical student reads this book. One of the terms in this book, there's a lot of sayings in this book. One of those sayings, if you don't check a temperature, you'll never find a fever. Which is great, because if you don't know a fever, you can send the patient home. You don't have to take care of them in the hospital if you're a resident and you want less work. So that's the deal as the federal government. If you don't look for a PSA, you're never going to find a prostate cancer. And once it's late and metastatic, you give them some morphine, you let them die. That's rationing. To get back to your Medicare question, remember the IPAB affects Medicare patients. If Obamacare says PSA testing is not preventive health services that they approve, they will not pay for PSA. If they will not pay for PSA, people won't get PSAs. Nobody will push to get PSAs. The doctors won't order it. And people will die. But it's okay to them because it's old people. Because remember, the people that put this together, Rahm Emanuel's brother, Ezekiel Emanuel, is a physician. And he wrote a paper 10 years ago or longer about the complete lives system, where he talks about that all healthcare resources need to be spent on those between the ages of 25 and 45. Those are the productive members of society. Unfortunately, I'm not part of that age group anymore, okay? I've aged out of that age group. That means that you shouldn't spend healthcare resources on those below 25 or above 45 because they're not productive members of society. This is the key doctor advising Obama, President Obama, about healthcare. Okay? This is what these people think. They're not shy about it. They publish this stuff. I mean, widely. So, let me tell you about this recommendation about PSA. I had a patient come to me. This is kind of a side note. I had a patient come to me, and they were truly. He was very distraught. He was a patient of mine, and he said, "I went to my primary care physician, and he was doing a physical on me." And I said, "Hey, make sure to do a PSA. Dr. Hampel wants the PSA because he checks it every year. I haven't had it this year yet, and that way I can get him the test because he wants it done every year." And his primary care physician told him no. And the patient was like, what do you mean no? He goes, "I refuse to do your PSA. It's a harmful test. It's a bad test." What happened was that the recommendation from that U.S. Preventive Services Task Force went into the family practice literature. Remember, the American Family Practice Association, they were supportive of Obamacare. The American Association of Pediatrics, the AMA, and the Family Practice Physicians, they all supported Obamacare. All the surgical specialists and a lot of medical specialists were opposed to it. So basically what happened is they took those recommendations and they published them into the family practice literature. So if you're a family practice physician, you don't know who's on this panel. You're saying, oh, well, that's the recommendations, and I shouldn't be doing this test. It's harmful. It's bad. It might harm patients, so I'm not doing it. So that physician decided he's not doing a PSA test. And so a patient comes to me and says, "Listen, do you mind, check my thyroid, throw my cholesterol, you're drawing my PSA, you're drawing my kidney function test, do you mind if you do a cholesterol too?" I'm like, "Hey, I don't care, here. Patient wants a test, why would I deny them a test? They're worried about something. It'll ease their mind, right?" It doesn't cost the doctors anything. The guy's a Medicare patient. Medicare is going to pay for that. Patient's not going to pay for that. What does that doctor care about ordering that PSA? But he was under the philosophy of, I'm going to do what's right, what the literature tells me. The literature told him, don't do a PSA. So the patient came to me. This was causing him a lot of anxiety. He was really, really worried. We did the PSA. It was normal again. It was normal the previous year. He doesn't have prostate cancer. We didn't have to do biopsies, nothing like that. But the point is, that caused the patient unnecessary stress until he came to see me for a couple of weeks, until he got his appointment. So the reality is it's happening. And it's going to happen in the Medicare patients first, to answer your question from before. It's rationing. And there are these boards, they're making recommendations, it's implemented, and there's no appeal. There's no appeal process. And that's what's really scary.
Have you heard or do you know anything about the compact law to where under the 10th Amendment the states can opt out of certain things?
Yeah, the healthcare compact, health insurance compact, that has gone nowhere. That was kicked around about 3-4 years ago. And I think what happens is that the state legislatures have not run with that ball.
There's 8 states that have passed that, and there's 12 pending from what I understand. But of course, when it gets to the Senate, the House is willing to pass it, but the Senate would not. But then, of course, since how it has federal dollars attached to it, the president may or may not have to sign off on it.
Yeah, it's a problem, and this is the problem with government controlling healthcare. The federal government has such its tentacles, and the thing about Obamacare is it's got tentacles. It reaches so many different areas, and remember, you're messing with a lot of money. You have to follow the dollars. And if you create a healthcare compact and do an end around Obamacare, there's a lot of people who have invested dollars in going after those Obamacare dollars. I mean, it's difficult, but
If we win the Senate, that we'll have any chance of changing any of this?
well, I don't know if the Republicans, Docs for Patient Care, the group I belong to, is actually nonpartisan. But the Democrats won't talk to us because if they talk health care, it's like they're going against President Obama, so they won't talk to us. Occasionally we'll talk to, one of their congressmen or one of their people, but as a general rule, they won't really publicly communicate with us. But the reality is that the Republicans have not stood their ground about defunding anything or stopping anything. So, the question is it Republicans or is it conservatives that are going to do this?
To the voters, I mean, if the voters have the stomach to get these people out that are not doing what they're supposed to do, that are more interested in getting home quick than staying up there and fighting for our rights, if we don't get out and vote, then it's our problem.
It's true. It's true. But remember, Obamacare hurts Republicans and Democrats and independents. It hurts everybody. I mean, it's really a bad thing, and I've seen it hurt my own patients. So, it's very sad.
On that note, we have been, I think American people in general have forgotten who's in charge. This nation states, we have the sovereignty, if we'll use it, at the state level. And what this gentleman's talking about is we keep appealing and petitioning the federal government when it's something the states can do themselves until we stand up against the federal government. It's like why appeal to the fox? He's guarding his own chicken coop. So we were created as a federal system, not a nationalist. In other words, not top down, but bottom up. And we've forgotten that. Until we get back to that, we're going to be, in the same pickle we're in now.
Right, and things like Obamacare could be an impetus for swinging the pendulum back to, reestablishing individual and state rights. And but a big part of this was, really started over 100 years ago, the 16th and 17th Amendment. Without the 16th, 17th Amendment, the federal government doesn't have the funds. That's the income tax. Doesn't have the funds to run it, and money is power. And the 17th Amendment is what made the Senate seats be elected by popular vote, which prior to that, the Senate was supposed to represent the individual states, and senators were appointed by the state legislatures. And if the senators did something that was against the rights of the states or the power of the states, they got replaced by the states, by the state legislatures. So those two moves, the 16th, 17th Amendment, is what created a big, powerful federal government and removed power from the individual and from the state and transferred that power to the federal government. And we see, in healthcare, we see it more than anywhere else. So.
Well, thanks, Ori. That was very, very educational.
It's hard to cover a 3,000-page law, and there's only one person I know who's read that law twice, and that's Louis Gohmert, who spoke here a while ago. And Congressman Gohmert actually read the law twice. I was in his office in Washington, and he pulled out the two large phone books, or at least I thought they looked like phone books, and what they were, those were the 2 volumes that are Obamacare. It's like a stack this big, and that's just the law. That's just a raw law, no regulations, nothing. And it's all highlighted. He read the thing through twice. And he has a crazy reputation of actually reading bills. He's like the only one in Congress that actually reads bills start to finish. He's insane. And or the only one responsible up there. And so it's hard to cover that. So, I try to pick up how certain things really affect individual people where I see that they can get affected. But the reality is it's terrible and it's unjust and it's bad for America. However, the American people are very resilient, and while there's still free enterprise in America, there are all kinds of little pockets of hope that sprout in medicine and in the cash and the economics of medicine. So it's going to be very interesting what happens over the next 3 years.
Thanks again, Ori. We really appreciate it. Okay, we're going to let's just close in prayer. We've run over some. We've got a deacons meeting that we've got to get to. So let me just close us out in prayer. Father, we're just very thankful that we have a heritage of freedom in this nation, a heritage of emphasis on the individual responsibility, that due to our heritage in a Judeo-Christian framework of thinking, that we've had this tremendous opportunity to promote individual freedom. And Father, we pray that we might have a populace that would once again appreciate that. We pray for internal changes in the thinking people and for men and women of courage and leadership who can point out how we're drifting and how we've shifted, and that people would be responsive to that information. We continue to pray for our leadership, that their eyes would be open to truth. And Father, we pray for us as individuals that we might have an impact on and involvement on our local to state and federal representatives, that we might be involved utilizing the opportunities we have to impact the system. And Father, we just pray all these things in Christ's name. Amen.